these are the phosphatonins, and you've got, FGF factor 23 is primarily responsible. Then you've got all this SFRP and a matrix extracellular phosphoglycoprotein. In fact, FGF growth factor 23 can be used as a diagnostic test for these, because that is what is responsible for the osteomalacia primarily. This can happen with any mesenchymal tumor. Okay, so this 79-year-old woman sustains this injury after a fall from a standing position. The question is read very carefully. What's the most cost-effective and evidence-based treatment? Surek. Can you see the fracture?
Yes.
The fracture line is there. Okay. Yeah. Sorry, what did you say?
Sliding hip screw.
Why? No, that's fine. Defend your argument.
Yes, there is a stable medial cortex is there. Also,
Sorry?
there is a stable lateral cortex is there. There is no medial comminution.
Yes, good. Isn't a short intramedullary nail, good enough?
No.
Yeah, I mean, I think the question is about cost-effective and evidence-based. I think when the lateral cortex is intact and it's a stable pattern, you think of a sliding hip screw. I think you guys need to read about sliding hip screw, and in exam, I'm sure you'll be asked at some point. Okay. Okay. What is the diagnosis of this? Anyone? What's this fracture called?
Bipartite patella.
Oh, that's not a good answer. Okay, it's not a bipartite. It's a traumatic event. Bipartite, where does it happen normally? Which part of the patella does it get involved? Sorry? Supralateral. So this is purely inferior, and you can see it's separate. And to give you a further clue, the patient can right leg raise. So it's essentially a discontinuity of the patella. Any names for this fracture? Give you a clue. Anyone? Sorry? No. This is called a sleeve fracture. Okay, so the whole sleeve of the cartilage comes off with the patella. Even though it looks like a small bony avulsion, the whole cartilage of the patella comes off. This is called a sleeve fracture. You need to study some of these specific pediatric fractures, specifically Cousins fracture around the proximal tibia. I think last time in the OSCE, I remember one of the examiners from Trivandrum who recently died was asking about that. Then you've got all these triplane fractures you need to know. So this sleeve fracture is one among them. You need to know that. And this happens around 8 to 12 years, and the treatment is open reduction and internal fixation if it's displaced. Okay, what is the diagnosis? What is the cause and symptoms, treatment? Anyone?
Gunstock deformity.
Yes,
it is cubitus varus.
Cubitus varus is the diagnosis. We are not asking about the deformity. You need to answer specifically.
Yes, cubitus varus.
Okay, what else?
Causes malunate supracondylar fracture.
Correct. Very good. Okay.
And symptoms, usually it is cosmetically. Patient won't be having.
I'll shoot you for that. I've told you so many times it's not cosmetic. What are the problems associated with this? I mean, it may be cosmetic, but there are other secondary problems that can rise from this. What are those? Anyone else? Yeah. Sorry?
Shoulder rotation.
No, it can cause rotatory instability of the elbow. It can cause ulnar nerve neuropraxia, ulnar nerve neuropathy. It can cause a snapping tricep syndrome. It can cause several problems. So it's not just this alone. Okay. So what's the treatment for this? How do you treat it? Give me one surgical treatment you would offer.
French osteotomy, sir. It is lateral
Yes.
closed osteotomy of
Yeah.
distal humerus.
So your option is an osteotomy. What are the different types of osteotomy you would do?
So either a lateral closing wedge or medial opening wedge,
Yes, good. Or
dome osteotomy.
yes, or dome osteotomy. Okay, fine. Advantage of a crossing wedge which you chose first.
Closing wedge.
Healing is more predictable.
Healing is more predictable.
Any crossing wedge healing is predictable. You need to know about how you derotate it. Normally, you put in with two screws proximally and distally, and the proximal screw you put in more posteriorly. I remember it by PP. So you put the proximal screw more posteriorly, and when you tie the figure of 8, normally they line up. So you need to remember, know the modified French osteotomy. And very rarely it's a malreduction is the primary cause, but very rarely you can have a physeal injury. Extremely rare. Okay, last two questions. Identify the surgeon. Right from Wikipedia.
Thomas.
Come on. Yeah, it's Hugh Owen Thomas. I mean, it's stupid to identify the surgeons, but you will be asked some questions like that. You will be asked some absolutely useless orthosis and all that, because I was also shocked to see some of the pictures, but that's how it goes. And even if one of the stations is not clear, you just you leave it. Don't panic, because most of the time they will discount that station completely if you cannot see or the video is not clear or something. So 3 contributions from this surgeon. Come on.
Thomas.
Sorry.
Thomas Flint.
Thomas Flint. Yes, good. What? One more.
Thomas French.
Yeah, Thomas French is there. Okay, another useless piece of invention. Okay. What else?
Thomas Kohler.
What is it? What test do you do?
Thomas test.
Okay, fine. Okay, good. That's good. Okay, the last question. I'm sure you will identify this person. Okay, so Jisam, your choice. I'm sure you will not miss it.
Sir, Thomas
test.
Sorry.
Thomas test. Thomas hip flexion test.
This is Thomas hip flexion test. Good. And 3 contributions. I think you have already answered. Okay. Fine. And what are the 3 contraindications to the test? Anyone? You better go and read it up. I think you guys need to know this. The contraindications is Thomas test absolutely, like the back of your hand. You need to go and read it up. I think I'm sure we'll be teaching you on that. I think I'll stop it at that. It's the first day. I won't bore you with too many things. Okay.